Hello, welcome to NU 621 Advanced Pathophysiology. This is week four's content session. My name is Dr. Christy Burks. We're going to get started. All right, so the first thing we're going to look at is the digestive system, which is regulated by various hormones and neurotransmitters. And the textbook does a great job offering tables and charts and figures that add to the visual learning. Um, so take a peek at that. Make sure you look at those. Some of them are presented in the information we're going to look at today and through these slides. And then you can also look at the supplemental PowerPoints, and they refer to some of the tables and figures and charts as well. Now, for this example, we are using the table 40.1, and it kind of goes over the selected hormones and neurotransmitters of the digestive system. And so this is a great table to be familiar with. It looks at the specific hormone or neurotransmitter, looks at the source, so whether or not it's from the mucosa of the stomach or the mucosa of the small intestine. And then it does go over the stimulus for secretion and even the action. So again, it's a great table to be familiar with. So just looking at this and breaking down the information just a little as an example, we're going to look at gastrin. So gastrin, the source of the mucosa of the stomach, and the stimulus for secretion is presence of partially digested proteins in the stomach. And that action stimulates the gastric glands to secrete hydrochloric acid or pepsinogen and even histamine. So the growth of that gastric mucosa. Now, gastrin is secreted by those G cells in the stomach, and it stimulates the gastric acid secretion by the parietal cells. And a simple issue such as excess of that gastrin can cause conditions like the Zollinger-Ellison syndrome, which we see as increased acid production, and it produces the peptic ulcers. So another to look at, let's look at secretin. So secretin, the source of mucosa is of the small intestine, and stimulus for the secretion is presence of chyme, that acid that is partially digested proteins and fats in the duodenum. And this action stimulates the pancreas to secrete alkaline pancreatic juice and liver to secrete that bile. So it decreases that GI motility and inhibits the gastrin and gastric acid secretion. Now, secretin is produced by S cells in the small intestine, and it stimulates bicarbonate secretion from the pancreas and inhibits that gastric acid secretion. So, a deficiency reduces pancreatic bicarbonate secretion, failing to neutralize stomach acid in the duodenum. And secretin is released in response to like low pH in the duodenum and the digestive tract. Another one to go over, for example, knowing which hormone is responsible for like the hunger, or the hunger hormone is what we call it. Like, and you can look at this table and see that it's ghrelin. The role of peptide YY, which is PYY in the digestion, which is to slow that gastric and small bowel emptying. So you can see the importance of kind of understanding what these hormones and neurotransmitters, which ones they are, and what they do for the source, stimulus for secretion, and that action. So take a look at it a little bit closer and make sure that you go further into details. Now we're going to go into just briefly about GI symptoms that we're all familiar with, but we're just going to review some additional information with each of them, okay? So looking at GI symptoms or gastrointestinal symptoms, we know nausea, vomiting, constipation, and diarrhea result from disruptions in the normal functioning of the GI tract. So looking first at nausea. Nausea is that sensation of that impending vomiting, often associated by stimulation of the chemoreceptor trigger zone in the brain or irritation of the GI tract. So it's that unpleasant sensation, often preceding vomiting. It can lead to hypersalivation and even tachycardia. And then when we look at vomiting, it's that forceful expulsion of stomach contents, which can be triggered by numerous or different various factors, including infections, medications, central nervous system disorders. And it involves a complex physiological process, including, that deep inspiration, the closure of the glottis, the relaxation of the lower esophageal sphincter, and then contraction of abdominal muscles, and then that reverse peristalsis, which helps with that action of vomiting. Now, we did talk about medications, but thinking through that, medications can be the chemotherapy drugs, narcotics. So there's several different ones that can do that. And we talked about infections, GI disorders, certain central nervous system issues, motion sickness, and even physiological or psychological factors like anxiety. So, complications of that could include dehydration, electrolyte imbalances, malnutrition, and even worsening aspiration pneumonia. So, if that vomitus is inhaled. So, treatment typically includes that antiemetic medications, fluid and electrolyte replacement, and then addressing, of course, the underlying cause. Non pharmacological approaches, we see ginger, acupuncture, even certain smells. So, using aromatherapy sometimes. And then chemotherapy induced nausea and vomiting, or CINV, is a specific concern because with various manifestations, the anticipatory or acute, delayed, or even breakthrough requiring that tailored management whenever you're doing the approach for that treatment. Next, we're going to talk quickly about constipation. So, constipation involves infrequent or difficult bowel movements, often due to that slow intestinal motility or insufficient fluid in the colon. Causes can include medications, especially from opioids, inadequate fiber intake, or just underlying health conditions. So, complications may include hemorrhoids, anal fissures, or even fecal impaction. So, treatment typically involves increasing dietary fiber, fluid intake, physical activity, and sometimes introducing treatment like laxatives or specific medications for opioid induced constipation. So, just depending again on the cause. Constipation occurs when there is that delayed colonic transit time. So that's what's resulting in difficult or infrequent bowel movements. So, thinking through the pathophysiology, it does involve several different potential factors. So, we're going to talk about a few of those. The first being decreased intestinal motility. So, this can be caused by inadequate dietary fiber. It can be caused by dehydration, lack of exercise or movement, certain medications like the opioids or anticholinergics, and then neurological disorders, and then even some of the metabolic disturbances that we see. The second being pelvic floor dysfunction. So, the inability to coordinate the abdominal, rectum, and even the pelvic floor muscles properly during defecation. And the third, looking at structural abnormalities, so conditions like strictures, tumors, rectoceles, or anal fissures that can obstruct the actual passage of stools. So we see that, unfortunately, when some types of colon cancer or colorectal cancer progresses and it has a tumor or something that is blocking, and that's one of the complications or one of the symptoms, first symptoms that may bring a patient in for treatment. Hormonal factors. So we talked about this a little bit when we were talking about thyroid. So low thyroid hormone levels, we know changes in hormones during pregnancy and then during some of those disease processes can actually slow the intestinal motility. And then the last, psychological factors. So ignoring the urge to defecate can actually cause issues. Stress, anxiety, and depression can contribute to constipation as well. All right. So just to recap, the slowed colonic transit leads to that excessive water absorption from stool. So when considering the process in which this occurs, it does include extended contact time. So as stool moves more slowly through the colon, it remains in contact with that intestinal wall for a longer period. And then that continued absorption. The colon's primary function is that water absorption. So even when transit is slowed, it continues to absorb water from the stool contents. And that's that reduced peristalsis, where the slower peristaltic contractions allow more time for water to be absorbed between movements, and that causes the hardening of stool. So, as more water is absorbed, the stool becomes harder, and that makes it more difficult to pass. And then we have that feedback loop where the harder stools further slow that transit, and that exacerbates the entire problem. So, this process kind of helps explain why constipation often results in that hard, dry stool that is very difficult to pass. So we've got to think about adequate fluid intake and maintaining regular bowel movements, which is very important to help prevent this excessive water absorption and maintain proper stool consistency. This can cause excessive straining, and that's what can lead to those anal fissures, hemorrhoids, and even fecal impaction if it's left untreated. Now, there are different classifications, there are different types, so we're going to talk about a few of those when we're looking at it. So, constipation, you can have the functional defecation disorder or functional constipation, and this involves normal stool passage rates but difficulty with that evacuation. Another type is slow transit constipation or STC, and that's characterized by impaired colonic motor activity, leading to that infrequent bowel movements, the straining, mild abdominal distension, and even palpable stool in the sigmoid colon. And the last one is constipation predominant irritable bowel syndrome, which we'll go into a little bit more in just a few other slides. But IBS-C, so this is associated with chronic constipation and abdominal pain. Now, these types can be overlapping and they're not mutually exclusive just to one type. So, constipation can be primary, which is idiopathic, or secondary. When we think of primary constipation, it results or may result from factors such as that diet. Genetics can play a role, colonic motility issues, absorption problems, socioeconomic status, daily behaviors, or even just that medication use that we talked about. Whereas secondary constipation can be caused by by a number of disease processes. So, looking or thinking through some of those disease processes when we think of that neurogenic disorder. So, some of our stroke patients, Parkinson's disease, spinal cord injuries or lesions, multiple sclerosis. Those are certain neurogenic disorders that we may see that altered colon transit time or that interfere or affect the neural pathways or neurotransmitters. So we talked a little bit about the endocrine and metabolic disorders last time, and that's that hypothyroidism, diabetes mellitus, even hypokalemia, hypercalcemia can contribute to constipation. So that's things to be considered. And then we already talked a little bit about the structural issues and rectal fissures, strictures, hemorrhoids, the pelvic hiatal hernia, which is another issue that can lead to it structurally. And then diverticular disease can cause constipation as well, along with those tumors or tumors that from cancer or just benign tumors. Now, medication induced. So we did look at certain medications, but even like antacids containing calcium carbonate or anticholinergic, iron supplements, and opioids, which all can slow that bowel motility. Depression, when we looked at psychosocial, so depression, it can actually impair bowel evacuation due to the lifestyle changes if you think through that process and the altered diet. And then, of course, pregnancy, which can cause constipation due to those hormonal changes and even just physical pressure on the intestines. So, again, treatment varies depending on underlying cause, but typically involves increasing that dietary fiber, fluid intake, physical activity, and sometimes the use of laxatives, stool softeners, or even a little bit more stronger laxatives and things to think about. So those medications typically that we use target that specific etiology that we're looking at. Like we talked about the opioid induced constipation, we look at specific medications that block that. All right, next we're going to look at bowel obstructions. There are different types of bowel obstructions, and that includes the first one is intestinal obstruction. So, in intestinal obstruction, we see edema of the intestinal wall that occurs due to that decreased venous return. This is a serious condition that occurs when the blood supply to a segment of the bowel is compromised, typically due to either twisting or constriction of the mesentery. So, the impaired venous drainage leads to that increased capillary permeability, the fluid accumulation in the intestinal wall, like the edema, and then potential ischemia and necrosis if it's left untreated. Now, one example is strangulated obstruction, and it's a medical emergency requiring immediate surgical intervention, and that's to help restore the blood flow and prevent that bowel necrosis or perforation, and potentially a life-threatening complication like peritonitis and even septic shock. So there's a couple different types. I've got one listed here, the intussusception, where you can see how it had the shortening of the bowel caused by the invulsion of one segment into the other side of the bowel. The next one is a volvulus, and uh, that is where it twists, and counterclockwise is the most common cause, and it gets twisted and causes that. And then the last one is a hernia. So a hernia can actually cause that issue as well as an obstruction. Now, another type of obstruction include the mechanical obstruction. So when we think of that, it's the hernias, but tumors, foreign bodies, and even adhesions from maybe previous surgeries. So there are some subtypes too. You have complete versus partial, and then simple versus strangulated, like what we talked about, the compromised blood flow. Then we have functional obstruction, and that is more like the paralytic ileus. So typical causes are those post-surgical electrolyte imbalances, medications, and even infections. And then we see small bowel obstructions, which are more common, but often due to adhesions. And then large bowel obstructions, which is unfortunately often due to those tumors or inflammatory disorders. You need to look at acute versus chronic, where we have acute as that sudden onset, usually mechanical, versus that chronic obstruction, which is gradual onset and often it's just partial. Closed loop obstructions, that's the blockage at 2 points, and it has the increased risk of strangulation. So that's something to think of. And then complications, of course, we talked about could be dehydration, electrolyte imbalances, bacterial overgrowth, intestinal ischemia, which is a very high concern for medical emergency, and then perforation leading to that peritonitis and septic shock. All right. The next thing we're going to go over is another symptom, diarrhea, which is characterized by those frequent loose stools and increased stool water excretion. So basically, when there is a disruption in the normal water absorption process in the intestines, leading to increased fluid intake or content in the stool. And this happens through several different mechanisms. And the first being osmotic effect. So unabsorbed substances in the intestine draw water into the lumen. The next is the secretory mechanisms, which increase the secretion of electrolytes and water into the intestinal lumen. And then motility changes. So you can have the rapid intestinal transit reduces the time for water absorption. Inflammation is another. Damage to the intestinal mucosa impairs the normal absorption. And then lastly, we have the decreased surface area. So conditions affecting the intestinal lining can actually reduce absorption capacity as well. These processes can be triggered by a various number of factors, and that includes infections, again, those medications, dietary issues, or underlying medical conditions. So we're going to talk about a few of those. The result is typically the frequent passage of loose, watery stools, and a few examples include of our medical conditions. Just one example is like short bowel syndrome. So following extensive intestinal resection, the complaint of chronic diarrhea because of the primary of cause is the diarrhea is malabsorption. So now there are other types. So when we look at types of diarrhea, we look at osmotic diarrhea, which is that lactose intolerance, and the complaint of they have symptoms of bloating, cramping, and diarrhea after dairy products. Secretory diarrhea is that acute onset of watery diarrhea after eating food. So it can be acute, lasting up to 2 weeks, or chronic, lasting over 3 to 4 weeks. Acute diarrhea is often associated with those infections, medications sometimes, and then dietary factors. While that chronic diarrhea may result from conditions like inflammatory bowel disease or irritable bowel syndrome. Now, we do have complications that we can see from this, which are similar to the other symptoms, the dehydration, electrolyte imbalances, and malnutrition. So again, our treatment focuses mainly on that fluid and electrolyte replacement and addressing the underlying cause. and in some cases using antidiarrheal medications. Although it's very important to understand the underlying cause before um, having patients take antidiarrheal medications, because if it's something like an infection, you don't want to slow that process. That's your body's natural way of get ridding the system of infection. So in all of these conditions, identifying and addressing the root cause is very important for effective management. Now let's talk about GERD. So gastroesophageal reflux disease. GERD is reflux of acid and pepsin or bile salts from the stomach into the esophagus, and this causes esophagitis. And we know that the role of gastric acid and pepsid in the development of esophageal injury in GERD, it causes inflammation and that erosive damage to the esophageal lining. So unfortunately, in North America, we look at the prevalence about 18 to 27% according to the textbook. So risk factors for GERD include obesity. Smoking can contribute to the main pathophysiology of GERD in a few ways. One way being the decreased lower esophageal sphincter pressure. So, nicotine in cigarette smoke relaxes the LES, or the lower esophageal sphincter, and that reduces its ability to maintain a barrier between the stomach and the esophagus. So, this allows stomach contents to reflux more easily. So, another way smoking can contribute to the main patho of this is that increased acid secretion. So, smoking stimulates the production of stomach acid, potentially exacerbating any kind of reflux symptoms when acid enters the esophagus. Now, additional risk factors include hiatal hernia, dietary factors like food choices, if we're thinking of fatty, fried foods, spicy, coffee, alcohol, and alcohol consumption is one that can lead to it as well. Then we think of medication. So certain types of medications put you at a higher risk for GERD. That includes the use or overuse of NSAIDs. Some people are more sensitive. They can take one or two of the NSAIDs, for something and cause additional GERD symptoms. Benzodiazepines can be a medication that increases that. And then some asthma medications. So that's interesting to make sure that you understand and talk to your patients about, particularly ones that relax that LES. Okay. Age is another risk factor. And then, unfortunately, pregnancy due to those hormonal changes and that increased amount of pressure as well. There are a few different types. We have the physiological reflux, and that's reflux without any symptoms. You have the non-erosive reflux disease, symptoms without visible esophageal injury. And then you have the erosive reflux esophagitis, which symptoms with mucosal injury. Clinical manifestations, the primary one is that heartburn or acid regurgitation, and then secondary includes dysphagia, chest pain, chronic cough, asthma attacks, laryngitis, and even hoarseness. So again, diagnosis based on history and clinical manifestations. Esophageal endoscopy is something that we have to look at, and then pH monitoring can be done as well. Treatment and education includes lifestyle modifications, weight reduction, smoking cessation. Sometimes elevating the head of the bed at night can help with that. Avoiding tight clothing around the belly can additionally help that. And dietary changes, talking about small, frequent meals, and then avoiding any trigger foods that they've identified. Medications we typically see used are those proton pump inhibitors. Now, there are some surgical options. We see the Nissen fundoplication or laparoscopic fundoplication. There's a magnetic sphincter augmentation, a radiofrequency ablation. So there's different things to think about surgically. Complications from the disease process include esophageal strictures. One that we see if GERD is left untreated is Barrett's esophagus. And then, although rare, we can see esophageal carcinoma. So that is something to consider as well. And the importance of getting that education and treatment and those lifestyle changes and modified. All right, next we're going to dive into GI bleeding or gastrointestinal bleeding, which GI bleeding is that acute massive blood loss, typically 100 mLs or 20-25% of your blood volume. Now, that beginning with the blood accumulation in the GI tract, and that irritates the mucosa and increases the peristalsis. This can lead to vomiting and or diarrhea. So with GI bleeding, you see an elevated BUN level and that's because of the increased digestion of blood proteins in the GI tract. Now, metabolic and lactic acidosis due to the tissue hypoxia are clinical manifestations, which are direct result of the body's compensatory failure due to that massive GI bleed. So when our body's dealing with a GI bleed, it tries to compensate in response, and one of those responses includes that blood volume depletion. So we have that decreased cardiac output. Another would be we see the systolic blood pressure drop typically below the 100 mark, typically, not always. Heart rate is increased, so you see some tachycardia. And then we start to see the peripheral arteries constrict to help shunt the blood to vital organs like our brain, our heart, lungs. Now, early signs include that postural hypotension, sometimes lightheadedness, visual changes, that pallor of the skin when we see the decreased skin perfusion, progressive deterioration. If bleeding continues and everything that our body's trying to respond to help fails, then we start to see cardiac complications. So you see that decreased coronary blood flow. So they may have an MI or an angina. Pulmonary edema, heart failure, dysrhythmias can start to occur. Renal complications, we think of alburia, tubular necrosis, metabolic acidosis, and then even renal failure. GI complications, so the mesenteric insufficiency, abdominal pain, a bowel infarction, and then even liver necrosis. Now, cerebral complications that you could see is decreased cerebral blood flow. You could see anxiety, confusion, even like a stupor or even coma, and then irreversible anoxic death. So that is something to think about on the GI bleeding. When we're talking about the worst complications. Now, so those key clinical points to remember: changes in the blood pressure and heart rate are typically the best indicators of the massive GI blood loss. When we think of our hemoglobin and hematocrit, they're not always reliable because in an acute bleeding, their GI bleed, the plasma and red blood cell volumes are lost proportionately. So these values only reflect blood loss after plasma volume is replaced. So now, chronic bleeding is something else to consider. Occult bleeding causes that slow iron depletion, leading to the iron deficiency anemia over time. So that is something to remember as well. And the severity depends on the volume and rate of blood loss, the patient's age, comorbidities, and of course, the treatment effectiveness. There are different types of GI bleeds. So we look at upper GI bleeding, and that location typically includes the esophagus, stomach, or duodenum, and causes characteristics like frank, bright red blood, or coffee grounds in the stool. Common causes include bleeding in esophageal or gastric varices, peptic ulcers, arterial venous malformations. And then we have lower GI bleeding, which we know the location tends to be in either the jejunum, ileum, colon, or the rectum. And we see characteristics of bright red blood in the stool or hematochezia. Common causes include polyps, diverticulitis, inflammatory bowel disease, that colorectal cancer it can be a symptom of, and then hemorrhoids. Fourth is occult GI bleeding. So that is that slow chronic blood loss not visibly apparent. So that results from that iron deficiency anemia, and the detection we use is that fecal occult blood test. Then there is acute severe GI bleeding, which we've kind of talked about, where that rapid large volume blood loss, potential complications, of course, is life-threatening hypovolemic shock. And then we have the chronic GI bleed, which is that slow, persistent blood loss over time. It's that gradual onset of anemia. Your clinical manifestations may include vomiting blood, melena, which is that dark tarry stools, hematochezia with that bright red blood in the stool, and then symptoms of blood loss where we talked about the tachycardia, hypotension, and even paler skin. So those are the managements. Whenever we think of treatment, we look at fluid resuscitation, blood transfusions if necessary, sometimes the evaluation and intervention between doing endoscopic procedures, colonoscopy or EGD, and then, of course, addressing the underlying cause. All right, next we're going to compare and contrast ulcerative colitis versus Crohn's disease. There are a few visuals from the textbook that I want you to take a look at, and you may find helpful when you're studying. There are also some in the supplemental PowerPoints as well. And this is just to help you think about each of the disease processes. So these images take a closer look at the type of damage done in the colon, as well as I've got a few that explore the colon closer to help identify different sections. So if you look at the image figure 40.13, it's from the textbook, and it's a great image of the sites of absorption of major nutrients, which is something to consider as we discuss these two disease processes, okay? Now, the image on the left side of the page compares a normal colon to one with ulcerative colitis. So we are going to start with ulcerative colitis, knowing that it is a chronic inflammatory disease that causes ulcerations of the colonic mucosa in the lining of the large intestine or colon and the rectum. So the inflammation begins in the rectum and extends proximally to the entire colon. Now, the body's immune system mistakenly attacks the intestinal lining, and that's what leads to the inflammation and ulceration. This results in clinical manifestations like diarrhea, often with blood or mucus, rectal bleeding, fatigue, weight loss, abdominal pain, and an urgent need to have bowel movements. Now, there are periods of remission and exacerbations. Often, if symptoms are or episodes are not controlled properly, patients can develop anxiety and depression just because of how it's impacting their life. Now, the inflammation can damage the intestinal lining over time, so increasing that risk of complications like colon cancer. So, when we think of exact causes, it's not necessarily unknown, but research does believe that involvement of genetics and environmental and even immune factors are possibly can play a role in that. Now, our treatment aims to reduce inflammation, manage those symptoms, and prevent complications. So there's different options like anti-inflammatory drugs, steroids, immunosuppressants, biologics, dietary modifications can assist, and then in severe cases, surgery may be needed. Now, ulcerative colitis can significantly, again, impact that quality of life of a patient. So if we do the proper treatment or have the proper treatment, they can achieve those long periods or longer periods of remission and help with decreasing that impact of the quality of life. All right. Next, we have an image 40.13 is shared here again, just so, again, it's a great image of the sites of absorption when you're thinking of major nutrients. And then we have figure 41.11, which shows the distribution patterns of Crohn's and ulcerative colitis, okay? So when we look at Crohn's disease, we also know it's a chronic inflammatory condition that can affect any part of the digestive system or GI tract. But most commonly, that's seen in the end of the small intestine or the ileum and beginning of the colon. So the body's immune system abnormally attacks the lining of the digestive tract, causing that inflammation. Now, this can lead to symptoms like abdominal pain, diarrhea, fatigue, weight loss, and malnutrition. So those skin lesions and inflammation, which can penetrate through all the layers of the bowel wall. Now, the inflammation can cause those deep ulcers and thickening of the intestinal wall, and the inflammation is patchy with healthy areas interspread between the diseased regions. So it's characteristic, that is the characteristic pattern of Crohn's disease. Now, again, it can affect any portion of the digestive tract, so from the mouth to the anus. So it is an idiopathic inflammatory disease. So that means the exact cause, again, is not known, but can, and research shows that can be possibly that genetic, immune, and environmental factors that can play a part to that. Now, they do know that smoking increases the risk and even the severity of Crohn's disease. Other characteristics, Crohn's disease is definitely characterized by those periods of remission and flare-ups. Complications can include strictures, where we see the narrowing of the intestines, fistulas, where they have the abnormal connection between the organs, and then increased risk of intestinal blockages or perforations. Abscesses can form, malabsorption can be an issue as well, or complication, where the treatment does aim to reduce the inflammation, help manage those symptoms, and prevent complications from occurring. Now, the treatment options typically include those anti-inflammatory drugs, immunosuppressants, biologics, nutritional support. Sometimes antibiotics are needed for the abscesses or fistula, and then unfortunately, surgery can be necessary to remove diseased intestinal segments in severe cases. Again, Crohn's disease is one that can impact significantly the quality of life of our patients. So you want to make sure that proper management can be achieved, so that way it can help with those, and encouraging those regular follow-up appointments for both of these disease processes, adherence to the treatment, and just being a part of the team, so that way they feel comfortable to share what symptoms they're seeing and the flare-ups that they're having, or the remissions versus the flares. Now, there are some pro-inflammatory cytokines that most implicated in that pathogenesis of both Crohn's disease and ulcerative colitis that I want to talk about. Now, this includes the tumor necrosis factor, or TNF alpha, and then we have some interleukins like interleukin 1, 6, and 12. And these cytokines contribute to that chronic inflammation and tissue damage that we see in these inflammatory bowel diseases like Crohn's and ulcerative colitis. So many of the drugs used to treat these conditions work by inhibiting or blocking the effects of the TNF alpha and those specific interleukins that we discussed. All right, let's take a look at IBS. Now, IBS, irritable bowel syndrome, I have an image here that shows a assembly line. So when I think visually of IBS, I think of an assembly line, because in IBS, there's a miscommunication between the brain. So I think of the brain as being my control center, or someone who is in control of that assembly line. And then we have the gut, which is the actual assembly line. So the brain sends signals incorrectly about how to process foods, leading to problems like spasms, motility issues, and even hypersensitivity. So that's just one way to think about it. Now, the miscommunication involves things like your serotonin imbalance, that gut microbiome changes, immune activation, and even psychological stress. Serotonin is one of the most common reasons in IBS that leads to that dysregulation of gut motility. But when the control center of the assembly line provides those confusing orders to the workers of the assembly line, they begin to struggle and the symptoms start to manifest. So the alterations in gut motility is behind the whole pathophysiology of IBS, and leading to either accelerated or slowed transit times, which contributes to either diarrhea or constipation, or even both. So other classic IBS symptoms include abdominal pain, bloating, diarrhea, and or constipation. The gut is still functioning, but it's not operating smoothly or efficiently due to that faulty brain-gut communication. Also review the box in the textbook 41.2, because it kind of reviews the diagnostic criteria for IBS as well. All right, let's look at ulcers. So ulcers, we have the term peptic ulcers, which is basically a broader category that includes both gastric and duodenal ulcers, and they're characterized by breaks or ulcerations in the protective mucosal lining of the stomach or proximal duodenum. So, some key points about peptic ulcers include they're caused by an imbalance between protective factors and destructive factors like gastric acid and pepsin. Main causes we see are that H. pylori infection and even that use or overuse of NSAIDs. Now, H. pylori damages the mucosal barrier, increases the acid secretion, and reduces bicarbonate production, and that allows the acid and pepsin to injure the mucosal. Additional some risk factors: corticosteroids, the bisphosphonates, potassium chloride, smoking, alcohol consumption, psychological stress, and even certain types of medical conditions, which can disrupt that mucosal defense or increase acid load. Um, Thinking of some of the conditions that can do that would be like obesity, COPD, and just even age, being over the age of 65 increases your risk. There can also be association with conditions like that Zollinger Ellison syndrome, which is that rare condition caused by gastrin secreting neuroendocrine tumor. And that it releases excessive amounts of hormone gastrin, which then stimulates the stomach to produce excessive hydrochloric acid. So usually in the pancreas or the duodenum, usually in the and that occurs. These tumors release those amounts or excessive amounts of that hormone. All right. Those high acid levels overwhelm the protective mechanism in the stomach and the duodenum, and that's what leads to the development of severe peptic ulcers in the stomach, the duodenum, and potentially the jejunum as well. Now, symptoms do include the abdominal pain, diarrhea, reflux, and poor appetite from the excess of the acid production. Now, other conditions such as systemic mastocytosis, cystic fibrosis, and even like hyperparathyroidism are associated with peptic ulcers as well. Complications could include hemorrhage, perforation, pyloric obstruction, and even intractable disease process. So, symptoms we talked about: abdominal pain, particularly between meals or at night. Treatment involves addressing that underlying cause. For example, the H. pylori eradication, if that's the issue or cause, and or reducing stomach acid with medications like proton pump inhibitors or H2 antagonists. All right, on this image here, it shows you different in this figure, there's a couple of them from the book. And so it's figure 42.9, which shows the appearance of benign gastric ulcer. And then you have 41.9, which is the duodenal ulcer. And then 41.7, which shows you an example of a chronic peptic ulcer as well. So talking about the main types of peptic ulcer, let's start with duodenal ulcers. Typically, the most common gastric ulcers due to the duodenum is exposed to that higher acid load. So it can be caused by the H. pylori infection or the use of NSAIDs and causing the acid and pepsin concentrations in the duodenum to penetrate the mucosal barrier, leading to ulceration. Tend to develop in the antrum near acid secreting mucosa due to the to the acid back diffusion or that pyloric sphincter dysfunction, allowing that bile to reflux. Now, it can occur in the upper portion of the duodenum. It's characterized by high gastric acid secretion. They have those deep, sharply those lesions penetrating through mucosa and submucosa. Chronic intermittent pain in the epigastric area is the complaints that patients usually have. And typically it's beginning that 30 minutes to 2 hours after eating when the stomach is empty. Pain can occur in the middle of the night and be gone by morning, and it can be relieved by ingesting food or antacids. Duodenal ulcers can hemorrhage or perforate, especially in patients that take excessive NSAIDs and or who are on anticoagulants. So that is something to be considered as well. Risk factors again include smoking, alcohol consumption, stress, certain types of medical conditions can contribute to that type of ulcer formation. Um, Now we look at gastric ulcers. Those tend to develop in the antral region adjacent to the acid secretion or acid secreting mucosa, similar to the duodenal ulcer as well. It develops in the atrium of the stomach near the acid secreting mucosa, often associated with chronic gastritis. Can cause or more likely to cause anorexia or vomiting than the duodenal ulcers. And the pattern of pain, food, and relief is common, but the pain with gastric ulcers can also occur right after eating as well. Then let's see. This last table image I have is our table of 41. Oops, sorry. Let me get back to it here. It is table 41. I've lost it all together. Bear with me. 41.6. There it goes. Okay. And it compares the characteristics of gastric and duodenal ulcers. So that is, I think it puts it together nicely and kind of goes over it pretty clearly. So take a peek at that. Make sure you review it a little bit more. We're going to move on to the next topic, which is gastritis. Now, there are two types of gastritis that we're going to look at, acute and chronic. When we think of acute gastritis, it is that sudden inflammation of the stomach lining. It can be caused by bacterial or viral infections. It unfortunately can be caused by excessive alcohol consumption, the use or overuse of NSAIDs. Stress can cause it, and even some of our autoimmune disorders can lead to gastritis or acute gastritis issues. Potential complications, though, do include stomach bleeding, ulcers, and dehydration. Chronic gastritis, on the other hand, is that long-lasting inflammation. It is often caused by H. pylori infection or autoimmune conditions like that pernicious anemia that we talked about. Now, over time, chronic gastritis increases the risk of stomach cancer, vitamin B12 deficiency anemia, and there are two different types, main types of chronic gastritis. So, chronic gastritis requires that long-term management to prevent serious complications. Now, looking at the types, there are two main types. There's actually more than two types, but we're going to look at chronic non-atrophic gastritis, which is also known as type B, which is non-immune, or it's known as chronic non-immune gastritis. So this type primarily affects the atrium, so that lower part of the stomach. It's often caused by that H. pylori infection, as well as those factors, alcohol, smoking, NSAID use. So there are those high levels of acid secretion increasing the risk of duodenal ulcers, and that chronic non-atrophic gastritis, which is often that H. pylori infection, causes that direct damage to the gastric mucosa and increases the risk of developing those duodenal ulcers. Um, the high levels of acid secretion associated with this type of gastritis can lead to that gastric ulcer formation that we were talking about. Now, chronic gastritis type B is a form of chronic atrial gastritis, primarily associated again with that H. pylori. Okay, remembering that the two most sensitive and specific tests for H. pylori include the organism specific stool antigen testing, and then you also have that urea breath test as well. Treatment involves antibiotic combinations and to help eliminate that H. pylori bacteria. And then additionally, using proton pump inhibitors along with antibiotics like amoxicillin, flagyl, tetracycline, things like that. And it's also based on resistant patterns and patient tolerance. So, modifications to lifestyle, such as avoiding alcohol, avoiding those NSAIDs, and even quitting smoking, is something that you have to do the patient education on. Complications can potentially progress to what we call pan gastritis. So if H. pylori infection spreads to involve the fundus, pangastritis, which is the type AB, where both types present together. The cancer risk increases the risk of gastric cancer, especially if it progresses to that pangastritis. All right, the second type that we're going to look at is the chronic atrophic, which is that type A immune mediated gastritis, also known as autoimmune gastritis. So this type affects the fundus or upper part of the stomach. It is an autoimmune condition where the body's immune system is attacking and destroying parietal cells that produce stomach acid, an intrinsic factor needed for that vitamin B12 absorption. Now, this is what can lead to pernicious anemia. It's associated with other autoimmune diseases and increases the risk of stomach cancer. All right. The last there, I know I mentioned the type AB, which is that pangastritis. The other type is type C, which is that chemical injury from bile or pancreatic secretion reflux. Now, both acute and chronic gastritis can lead to symptoms associated very similar. So that abdominal pain, nausea, vomiting, and the loss of appetite, especially if it's not properly treated. Okay. Now we're going to move on to the last topic that we're going to talk about today, which is hepatitis. So hepatitis is that inflammatory condition of the liver caused by viral infections or other factors like alcohol consumption or autoimmune disorders. So table 41.9 reviews the characteristics of viral hepatitis, and it kind of contrasts all of them. So it's nice to look at that and review it. Now, the main types of hepatitis include A, B, C, D, and E viruses. Again, these viruses primarily attack and damage the liver cells called hepatocytes, and the body's immune response to the viral infection leads to the inflammation and further liver injury. Now, chronic hepatitis B and C infections can persist for years, causing ongoing inflammation that leads to fibrosis or scarring of the liver, and eventually cirrhosis. So that's severe scarring of the liver or over time. Now, cirrhosis impairs the liver's function and increases the risk for liver failure or even liver cancer. The pathophysiology of viral hepatitis involves that viral replication, immune-mediated hepatocyte damage, oxidative stress, and progressive fibrosis, disrupting the liver's structure and function. So the degree of liver damage depends on factors like the virus type, individual's immune response, and presence of other liver conditions. All right. Quickly looking at a couple types. So when we look at hepatitis A, it's primarily spread through the ingestion of contaminated water or food, or both. The most common source being contaminated water supplies. So like proper hygiene, safe food handling, and access to clean water is very important for prevention when we see hepatitis A outbreaks. Hepatitis B. So, hepatitis B virus, we know transmitted sexually or by exposure through a break in the skin, a mucosa membrane is pierced, such as human bites or cuts or abrasions or needle sticks. That's why healthcare workers are increased risk for hepatitis B. And then we have the additional types like hepatitis D and E as well. But hepatitis C is another one that we see. So, chronic hepatitis C. Treatment it can't be treated with it can't be treated with a vaccine, but it does involve the use of a direct acting antiviral medication orally for about 12 weeks now. Treatment for hepatitis involves antiviral medications. Hepatitis C is transmitted blood to blood contact, vertical transmission, so like mom to baby, and then percutaneous exposure, and unfortunately can go undiagnosed because there may not be symptoms for a while or a long while. I worked with a nursing supervisor of the hospital that she believes she knows when she contracted hepatitis C back I think she said like 20 years ago, before, when she had a stick and they had been monitoring her, but she didn't have any symptoms and nothing showed up. So moving forward, 20 years later, when there was actual damage, that's when she was diagnosed, and they linked it back to that exposure. So that is something to think about. Now, one symptom we do tend to see with hepatitis is jaundice. While it's important to remember that jaundice can have different causes, but it is one of the associated manifestations that we see. So, jaundice causes can include obstructive, so blockage of those in the bile ducts, preventing excretion of bilirubin, such as gallstones, tumors, or inflammation. But one of the key mechanisms of obstructive jaundice is cirrhosis, or in cirrhosis of is the excessive scar tissue, that fibrosis that compresses and obstructs the bile ducts within the liver. Now, as cirrhosis progresses, the accumulation of fibrous scar tissue distorts the liver architecture and can extrinsically compress the bile duct system, impeding that normal flow of bile out of the liver. And this obstruction leads to the buildup of bilirubin and other bile constituents, gosh, of other bile, so resulting in that obstructive jaundice. Now, when looking at cirrhosis, it is one of the major complications of that chronic viral hepatitis. So, particularly in Hep B and C infections. So, that long term inflammation caused by these viral infections over many years can lead to that progressive scarring and fibrosis that of the liver that we talked about. So, the excessive accumulation of scar tissue distorts that liver, and that's what impairs the normal liver function. All right. I do believe that concludes our content session for week 4. If you have any questions, please reach out and email me. And I appreciate it. I'll see you guys next week. Thank you.